if you say about test players like Umar Gul,
sorry, but that on is very disturbing. Is it addition or it has some pathomechanics of on lumbar spine? See, that is very confusing.
I missed it.
So I thought probably I'm not understanding.
While I was doing those slides, I missed something. I don't know what I missed. Even I don't know what I missed.
You missed deleting.
Yeah. Mechanics and pathomechanics of lumbar spine. Thank you very much.
Normal problem.
Thank you very much. Thank you very much. No, actually, I did a lot of work with this thing. Please don't say that to me. So what happened that we had stress fractures with Umar Gul. We have stress fractures. Very talented player. Whatever happened to him next is Mohammad Amir.
Again, one more question, if you don't mind.
Sir.
See, this is also Dr. Beg also mentioned one name earlier in the lecture. Like you see, there was a deliberation on ethical part that you see there is a confidentiality and privacy. Just to cover that medical ethical part also, when we are discussing even within the professionals. My question is that whether that comes into it when we mention the name of our patients to even our colleagues, or we can do it easily, like you see that.
Dr. Nadeem, my case was totally different. That was one of the scenario, and so it wasn't happening on the ground. So it's fairly normal happening with any of the players. There's nothing to do with his injury surveillance or his privacy.
For example, let's say, for example, there is a cosmetic surgeon.
Cosmetic surgery is not involved.
No, I'm giving you an example. There is a cosmetic surgeon who is telling the other cosmetic surgeons, and
yes, I have done
this on Julia Roberts,
yeah.
And that nose is mine. So would that come into ethical part or not?
That is.
So when you say Sohail, I mean that's the question, because I asked that question. You see that the confidentiality
and
the privacy in the code of ethics. Especially with the medical ethic code, do we have that, you see, because that is the question. Should we mentioning it? Is it okay to...
As far as the injury part is concerned, the management part is concerned, and the way the procedure is concerned, that has to be discussed.
So we can always mention that.
No, we should not take the names of individuals. We can say there was a case, target, subject, something. No, there is no need of
It is like mutual, like
I think
we are all healthcare people.
may have.
And if we feel that yes, we can go ahead with it, I mean that's perfectly alright. I just wanted to clear the concept.
It is just to create interest.
Just to create by knowing certain names can also get injured and they can be treated with time.
Sorry.
Sir, Dr. Nadeem is quite in habit of creating such sort of scenarios.
That's excellent, actually.
Excellent.
Yesterday also,
very tough,
very good questions, and especially like he mentioned, nobody mentioned it, where the phone is coming from.
He can replace how many
Salary कितनी मिलेगी?
बस अमन मीरा का सवाल करता है.
The problem is, okay, let me answer to your question. The problem is that why we teach Umar Gul? Why I take that name Umar Gul? Umar Gul had this fracture in his first test match. Amir had his fractures before he started his career as a test player. The thing is that, yes, I want to say that we are not so naive. We have worked with them without any help, and they became one of the best bowlers in Pakistan. Even Amir, I'm not saying about the other thing, but Amir was the most talented bowler we ever had. And that's what I'm telling you, that before even he came to cricket, when you saw him bowling on TV, he had 3 stress fractures of the back because of his action. And referring back to the biomechanical part also, we not only had his injury treated, but we had his action corrected, and action corrected because we worked in the biomechanics of that hospital. Similarly, Umar Gul, if you see his first test match and if you see his about 3rd test match, you would see a difference in his fast bowling, because there was data and we actually looked into the data and we knew that this injury is happening because of their fast falling biomechanics. So that's why I mentioned, and as Tosif said, that's because in order to create that interest in the people, that okay, let's talk about this. Regarding confidentiality, sir, I think so. Confidentiality of these injuries, they were never published in the paper. They were passed, they did not knew it, and I have another attitude about these things. That from the personal point of view of the player, yes, we must talk that. But when we are like talking into these conferences, so that somewhere, someday, somebody will come up, okay, can we share something with you? Can we share how you did that? You may come up with a patient, whether it's a fast bowler, just bowling in the streets with a tennis courts. He come up to you and he say, I have a pain which is not going after 1 year. And nobody is looking at what is happening to this point. Because, honestly, believe me that saying about some cricket board, you have on daily basis, there are about 10 to 12, 15 local boys are coming to us. Not for this injury, but all the injuries. They do come to us, they refer to us, and we try to help them. But there would be thousands on the streets who would have this fracture and they would not. So in order to that, somebody somewhere from this crowd had a patient coming to him or her, just from his medical point of view or from physiotherapy point of view, just thinks that he has got the past fracture. Let's talk to Dr. Sohail, or let's talk to Dr. Bakar, or let's use something, or someone who knows this past fracture. That's why we mentioned these things. Sorry for the answer. Okay, I'll run through the bony and yes, sir. Kindly.
I mean, we ate snakes yesterday, so it's okay.
Now, believe me, it's more than that. Believe me, it's more than that. So let's see. I'll rush to the bony anatomy, and I'll be mentioning a couple of things in the bony anatomy because that is pertinent and important for the stress fractures of the past, fractures of the back. People, I mean, how many you know? How many of the crowd knows that what is bars? Yes. What's the pars articularis stress fracture and how it happens? Please raise your hands and can you explain that?
Pars articularis fracture can occur following a trauma. Say somebody faces a twisting or an injury in which the spine is, say, a player is playing and another player falls on the back of that player.
No. Sorry, not Papa. It's not like that. It's a pars is a typical stress fracture of the back happening due to not due to trauma, biomechanical fault of the back. And in parts we can't. It's not that easy.
It's the twisted position of the player actually, and a superimposed trauma due to another player might, because say,
No.
Sir, I just saw a case 3 days back.
It could be another sport.
And in which you write the biomechanics, it was initially it was the player's fault. He was in a wrong biomechanical position actually, and
Could
he
be,
had
yeah.
himself twisted himself. So he was somewhere, and he was his body was not even. It was.
And that fracture was where?
Pars articularis. It just mentioned. This is an X-ray finding actually, and there was not even an MRI done. He's into that phase, but that it was very prominent on the X-ray, and then we discussed it out with the radiologist, and then you're right. It is actually the biomechanical fault of the player, and then a superimposed where the player fell on him, he lost his balance, and followed by.
True, it can happen. That's true, it can happen. But in my mind, this cricket world, and in one of the gymnasts, I saw that definitely happening because of the extension and rotation, superimposed rotation. Okay, let's go through this anatomy thing a little quickly. Most of the doctors and physiotherapists would be knowing I'm talking about particularly the lumbar vertebra. Body, sphere articular facet, there is inferior articular facet and transverse process in that. Then we have what plates. Why we have, I would let you know a little while. In upright postures, the bodies of the lumbar vertebra assumes 80 to 90% of the compressive load this is the point where I was actually trying to come. In upright posture, remember that in upright posture, this is the vertebral bodies who actually are taking 80 to 90% of the compressive load. Now, load on a spine could be that what you're talking about is a torsional load and a compressive load. And then there are sagittal rotation, which is sagittal rotation is going, asking the vertebra to go forward or backward. That is the sagittal rotation. Torsional load is this, compressive load is this, torsional load is this, and if a vertebra moves on the other vertebra, which is called a sagittal rotation, where a vertebra moves forward or backwards, anteriorly or posteriorly, that is called the sagittal rotation of the. Now, what happens? The compressive load, 80% of the compressive load, 80 to 90% of the compressive load is borne by the body of the vertebra. How it is borne? Let's see what happens. The compressive load bearing, vertebra bears this load because of three reasons: biconcaval arrangement of the vertebra by itself, vertical and transverse trabecular arrangement, but lacks oblique orientation. Let me show you something. This is the trabecular arrangement. Can you see it clearly? I'm sorry, this is a very bad slide. There is a vertical and horizontal arrangement of the trabecula in the bone by itself. But there are no oblique arrangements of the trabecula. So what happens? If you're looking at the vertebra, this is the superior end and this is the inferior end, and you have a compressive load. What happens? There is hemopoietic tissue within this space. There is a space, these spaces, there is a hemopoietic tissue, there is a blood and other tissue also, which get compressed, and you get the resilience from compressive loads. Have you got it? Everyone is with me or sleeping? It is quite a chance. But these vertebrae, they cannot bear the torsional load, this body of the vertebrae. Why? Because they don't have that obliquely oriented trabeculars. Now, as I told you, torsion is like that. So they can't bear that torsional load. How? And then who bears that torsional load? That is your posterior structures. That is your neural arch. That is your facet joints. That bears your torsional load. That's why these bodies, they can only bear compressive loads. Going back, the third word, there is a potential spaces between the trabecula, and this is occupied by blood and hemopoietic tissue. That's why they bear that compressive load. Rotational stress are compensated by the intervertebral discs and posterior bony structures. Now, if you remember the structure of IVDs, intervertebral discs. I'm sorry for the people who are non-doctors, I'm really sorry. If you remember the structure of intervertebral discs, if you see the annulus fibrosus, there are more obliquely oriented fibers than vertically or horizontally arranged fibers. That's why IVDs, with the help of the posterior bony structures, bear most of the torsional load of your vertebrae. I'm not going through the details of the article of essence because my basic talk, this is a part of my course, so I'm going through this quickly, and we're going to go into this muscular side of it. Now, let me talk about a little bit about the spondylosis, because it is not very common in sportsmen, but it is still there in sportsmen. So let's talk about what we call stress fractures of the back or stress fractures of the fast intra-articularis. Remember, in right-hand fast bowlers, you may have these fractures on the left side, and on the left, in the left-hand bowlers, you are suspecting these fractures on their right side. Because now, what happens in fast bowling? Let me give you a little biomechanics of that. When a person right-handed bowler, he comes to bowl, the people who get the most fractures are those people who just go back and then rotate and then deliver the ball. Now imagine I told you that this is a torsion. I told you earlier in my talk that this is a torsional stress on the bone. Now, these posterior vertebrae can bear this load to an extent, but if you're repetitively going in extension and doing this rotation, counter rotation, also remember that rotation at the lumbar vertebra is only 1 to 2 degrees, not more than that. All the rotation which is coming, like I'm talking about this rotation, this is coming from the thoracic, not from the lumbar at all. Lumbar has only 1 to 2% of rotation, and that too is coupled with other movements of the vertebrae by itself. Are you with me or sleeping? Thank you. So what we have, when we have repetitive torsional stress on the vertebra, these pedicles, the space between the inferior and superior facet, they fails, and there is a fracture in this side. This is called spondylolysis. That's why we talked about these bony structures. Now, let's talk about, as Sir said, the snakes. No, this is even that, more than that. What you call it? Okay. Whatever. Now, 2 important points to remember about the muscles. Let's talk about all the muscles, not the lumbar muscles. Two important things always remember about muscles. That one, force production potential of the muscle. How much force a muscle can produce. This is determined by, initially we used to, back somewhere couple of years, a couple of decades back, not a couple of years, but a couple of decades back, we used to say that's a force production ability of a muscle is his total cross-sectional area. Like, let me give you an example. Let's say a Phalwan, a person, have deltoid, and we would say he would produce, or he would just pump this about 100 kgs of these dumbbells, and they would determine that his cross-sectional area of the total muscle is causing that force-producing activity in that muscle. But now they are saying that this force-producing potential is produced by only the physiological cross-sectional area. What is that physiological cross-sectional area? What happens, as in quadriceps, remember, if you remember the muscle fibers of the quadriceps, they start from here, go to the knee. But some of the muscles, they end up here. Because they are phenate muscles, they end here. And if you take cross-sectional area from here, if the line of action, in females you see that they say that they have greater Q angles. That's why, and they have valgus knees, and they have more chances. The badminton thing we saw yesterday, female are predisposed to having ACL or medial collateral ligament tears because of the greater Q angle. Greater Q angle of the quadriceps is, line of action of the quadriceps is more inward because of the wider pelvis, and their knees a little closer. So because of the wider pelvis, they have a little, there is a study which says that. And they have greater Q angle. But in males, now this is the line of action of the Q angle, the line of action of these muscles. Now we have, a male athlete have a better line of action of these muscles, so that's why the force producing potential of that muscle in male is more than a female. You got it? So that's the line of action and the movement arm of that muscle, which is important for us. Now let's talk about something about the rotator and muscles acting on the lumbar spine. I don't know about the guys over here, brilliant crowd, but it is very recently I have come to know really about the muscles of the lumbar spine. Really, honestly speaking, if you talk about, you would read a lot of literature, and at the end of the day, you would say, where this erectus spinae is. Sir, I'm right? Where this, Doc, what do you say? Where this erectus spinae is, why this multifidus, how come they are interlapping and doing these things up? This was until recently I solved the dilemma for myself. Let's see if you could solve the dilemma for yourself with this neckish torque. Now, here is bone lumbar. For me, that's purely my own thought about a couple of years back, that there would be some muscles who would be statically acting on any of the bones or any of the joints, like lumbar spine. There should be muscles which don't have a function of moving the joint. We just have the function of stabilizing the joint. The usher muscles, the other muscles, which are bigger muscles, they would be doing the functional part of movement of that joint. For me, I always thought, probably that was right for me, that the muscles which are more deeper, they are the static muscles stabilizing the joints, and muscles which are superficial muscles and bigger muscles, they are the dynamic muscles which move your joint or which move your arm or something. So, when I read about this rotators and intertransversi, never heard of them before. I was like, in a trouble. What these rotators and transversi and where they are. Let's see what happens with this spine. You please watch this very carefully. Now here we are. We have actually jumped into that. Now these smaller muscles, here, these muscles are called the intertransversi. As the name suggests, these are the muscles which are between the two transverse processes of the successive vertebrae. Or they may go up one level from, for example, from L3 to L1, they may go to the L3. So these are intertransversi muscles, and the second group of muscles, which is not very much developed in the human beings, but they are still stated, are these muscles, smaller, tiny muscles, which are they call rotators. Now, rotators, as the name suggests, and as the scientists called it, they must be the rotators of the spine. And if you see the anatomy of, if you read the anatomy of this intertransversi, that is attached from one intertransversi, from the one transverse process to other transverse process. So presumably what their function would be. Let's see. Rotators, what the function of the rotators would be? Rotate, okay, fine, fantastic. And what the function of the intertransversi would be? Because they are linking the transverse process, so they would be forming, doing that lateral rotation also, lateral bending or lateral flexion also, if they are between two transversi. But honestly, to my surprise, this was not the case. These again here. Then these are anterior intertransversi. They were anterior and they were posterior intertransversi. They are very strong muscle in that case. They are strong muscle in that case, and they would be performing the lateral flexion. Do these muscle causes axial twists and top lateral flexion respectively, which is mentioned in your anatomical books? I'm sorry, they don't. Two reasons. We discussed in the beginning. One reason, their line of action. And the second reason, they have small movement arm. Even this one. How could even they are multiplied into 12 muscles, 21 muscles, 31 muscles, going up the spine, how could they perform? And another important thing, as we said earlier in the talk, that there is almost a non-existing rotation in the lumbar spine. So there is no chance that these muscles would be existing there. So, what they are doing there? Are they stabilizing the vertebra? Stabilizing. Okay. My voice says that they are stabilizing the vertebra.
Yes.
Problem is that they are not stabilizing the vertebra. It's the latest EMG studies which says that they have called. Sorry?
Rudimentary?
Sorry?
Rudimentary?
No, not rudimentary. They have very important function. They work through a small movement arm, and their total contribution to the rotational acceleration and bending torque is minimal. They have the minimal contribution. And what they are doing there, these muscles are highly rich in muscle spindles, 4.5 to 7 times more than multifidus that big muscle has. So they have muscle spindles. If they have muscle spindles, then what their function would be? That's sensory. If they have so much of muscle spindles in them, 7 times more than this quadratus lumborum or multifidus, then they would have a sensory function. Now, where I'm bringing you to, the problem, I've done some certification courses in manual therapy, especially on spine. The problem would be, so they are length transducers. Their function there is as a length transducers, not moving or stabilizing the spine. Okay, minimal function would be there, but main function is to do that. Its clinical significance for the physiotherapist in the various type of manual therapy with a joint end range of motion, it is very likely that these structures are affected. Now, if you remember your manipulation at the end range of the movement of the lumbar spine, so what you are actually trying to do, these small muscles taking to the end range, moving a vertebra, and then destroying those muscles. And there would be more pain in the lumbar area because they were sensory transmitters of the pain. So you would be looking everywhere around quadratus lumborum, multifidus, saying disc prolapse, this, that, but probably these muscles would be interfering. Now, the true extensions of lumbar spine, we have the major extension of lumbar spine as multifidus group. I call this multifidus group, I will let you know later why this is called a multifidus group. Now let's go back. Let's go back to our original interactive spine. Let's build on the muscles so that you should remember from now onwards, at least if you remember one muscle, my job would be done, how you dwell at this point. This is a multifidus. Then next, what we have? Some muscles in the ribs. Next, this is quadratus lumborum anyway. Then we are starting to develop the erector spinae muscle. So we have intertransversi down there with the vertebrae. On top of that, we have multifidus, and on top of that, we have erector spinae. There are 3 muscles in the erector spinae group. The 3 muscles in the erector spinae group are spinalis. Spinalis, most medially, we have iliocostalis, longissimus in the middle, and iliocostalis on the lateral side. Where these muscles are, okay, let's work a little bit. I'm actually sorry, forgot to do that we haven't mentioned over here. Extensions of the lumbar spine, the 3 major extensions, multifidus group, longissimus, iliocostalis, and the multifidus group. This is what I told you, this multifidus starts back there, going up there. Now, here is neckish thing. That's the problem. Now, if you go back on the slides, and first read this. There are 5 short fascicles are the deepest, which occur from the caudal and dorsal surface of each lamina and insert into the mammillary process of the vertebra, 2 levels caudally. Even I am confused what I'm reading. Let me show you what I mean by this. Here you are. Multifidus have 5 fascicles. It's not just one muscle going from there to up there. It is 5 slips going down to the vertebrae. From one vertebra, sacrum, Iliolumbar ligament. Now, what happens? The first fascicle, the deepest fascicle, is joining one vertebra to other vertebra. The second fascicles probably joining one vertebra inferior superiorly or one vertebra inferior, so they are a bit longer muscles. The third, and that would be joining the sacrum somewhere down there. So they are connecting your sacrum with your lumbar vertebrae now. Then, if you go a little, if you go a little down, they have sacrum involved. The typically you call that joint, which is the posterior joint, sacroiliac joint, somewhere on the sacrum, and ilium also. These muscles are coming. So there are 5 fascicles which actually consolidate your lumbar vertebra on your pelvic bones. Got the point? That's why they have 5 fascicles and they are starting from down there, from level of the sacrum. I always call how I remembered them. It's a typical Pakistani style. I remember that. Never remembered those words. Now, this sacral area is somewhere near your pocket, back pocket. And its origin is this origin of this erector spinae, we will talk later. It is just like a pocket on your sacrum and ilium. And you have multifidus in that. From money, M, and multifidus M, I remember that erector spinae is the pocket and the money is lying into your, multifidus is lying into your erector spinae. So that's how I remember about multifidus and the erector spinae muscles. According to Gray et al., now the functions of these multifidus, they are capable of producing extension, lateral flexion, and lateral rotation. What do you say about this? Nobody's saying we're going to say no, because whatever they're going to say, I'm going to say no. Okay? My boys, yeah, because I started with extension, you are very intelligent. They are capable of producing, yes, they are capable of producing extension, lateral flexion. However, when multifidi are studied as individuals, add individual muscles, they seem to act more as stabilizers than the movers of the vertebrae column. Because remember the 5 short slips of multifidi. They're short slips from one vertebra going toward one second vertebra, the deepest part. So basically, okay, they are extensors, but they are used more as stabilizers of the vertebra. And remember, I told you earlier that also, that the more deeper the muscle, the more stabilizers they are.
Grace also has mentioned this thing. They are capable of doing extension, but the main function is the stabilization.
Yeah, I mean, it's the, yeah. And electromyographic studies confirm their role in controlling the intersegmental motion, which means that they didn't perform extension and just performed the movement of one vertebra to other vertebra, and they found out that multifidus fibers are active. So which means, and when they performed the extension, they were less active as compared to the previous movement. McIntosh and Burrow confirmed biomechanical function of the multifida as a posterior sagittal rotation of the lumbar vertebra. This is what I told you earlier, that remember, this is a sagittal section, and if they are moving in this direction, these vertebrae are moving, and this would be anterior sagittal movement or anterior sagittal rotation. A little bit of rotation is added into that, that's why it's called rotation. And this is the posterior sagittal rotation. So what happens? When you flex, the multifidi are there, they contract, not to act as an antagonist to your flexion. It is actually to control the movement of the vertebra. Multifida pose the flexion effect of the abdominal muscles as they produce rotation. That's what we will come to this point later, what this exactly is. And now the erector spinae group, longissimus and erectus longissimus and iliocostalis are. Now please, just for a couple of minutes, please carefully listen to this because it has got a very good clinical implications. People who are treating the back of whatever, not sportsmen only. It's for common people also, that people who are treating back, what we are actually doing and what we should not be doing. Especially from my own point of view, if I have a clinical practice of about 15 patients a day, I would have about 7 patients for the back, off the back. But what is happening? We have been doing this. All of us have been doing this. What? Now, longissimus and iliocostalis. Let me show you again to keep you abreast with what I'm doing. Let's deviate the spine a little. Now where this erectus spinae whole group, erectus spinae where this is the whole erectus spinae group. Let's see. Spinalis is the most medial of this group. Second to come would be longissimus. This is longissimus. This is longissimus. Spinalis would be here. Longissimus is this. And the third one would be iliocostalis. Now, to remember that, again, Pakistani style, SLI, Saleem, they are part of the erectus spinalis. So I remember them, and this is a part of erectus spinae group. This whole group is called erectus spinae. Now remember, why I'm telling you this, that why I'm telling you original insertion of these muscles. Because if you take original insertion of these muscles, again, these muscles are starting somewhere up in the thoracic region and going to this pocket. What I said, the overswing pockets of your back. These muscles, they start from here, go till here. Right. No doubt there are 3 muscles, but what's the deal? Now, in anatomy books, longissimus and iliocostalis are separated, but functionally and architecturally, let's separate them into the thoracic and lumbar groups. Why I'm going to tell you. Now, remember again, I'm going back to that point that they start somewhere in the thoracic region and go into the lumbar. Do they have anything to do that with the thoracic region? So why they are there? Why these muscles, spinalis, iliocostalis, and they start from the thoracic region and somewhere even in the cervical spine also. Why they start from there? Remember one thing, as we started earlier, that it is the line of action of these muscles. Now, had they been very small muscles, their movement arm would have been like this. So they wouldn't have produced the extension, but now in order to produce extension they have to have a long movement arm. Un muscles ko lamba hona tha. They have to be bigger muscles. So in order to have an extension, this extension, they have this long movement arm, muscle arising. Actually don't do anything in the thoracic region. Iliocostalis, spinalis, and this longissimus, they don't do anything potentially in the thoracic region, but they still start in the thoracic region and go up till that lumbar region. Now, the anatomy books separated. You got the breather. So they start from the thoracic region and go to the lumbar region. Now, what the previous anatomy book said that if this is longissimus and this is iliocostalis, okay, we separate them as a two different muscles. But now they have separated these muscles horizontally. They have divided these muscles, that muscles which are arising in the thoracic region. Let's call them pars thoracic iliocostalis and pars thoracic longissimus. And the muscles which are arising below that horizontal line, they would be called as pars lumborum muscles. Because, why we divided that into these two portions? Because thoracic portions have 75% of the slow twitch fibers, whereas the muscles which are arising, the iliocostalis and this longissimus are rising below that particular thoracic line, they have mixed type of fibers. So it was easy for them to divide these muscles into slow twitch fibers and the mixed type of fibers. If they have slow twitch fibers, what do they do? Good, excellent. If they have slow twitch fibers, it means that lumbar posture is being controlled by the thoracic portion. Most of the lumbar posture is controlled by your thoracic muscles. Agreed? And okay, 50%, because they have mixed fibers, 50% of the lumbar posture is being controlled by the lumborum area. Right? So why, while working in physiotherapy, we work on the lumbar portion and we don't work on the thoracic portion? That's the point. That's where I was trying to bring you guys. That's where I'm trying to tell you that please don't work only on the thoracic lumbar region. You have to see. Now, honestly speaking, I'm very fond of surface anatomy, as you guys know. Very fond of surface anatomy. This muscle is here, this muscle is there. They are lying over here. Okay, you can say that. Now, if you remember, who is with that simple? You have to take your shirt off. Are you? No, not from the back. I'm not going to show you, Tommy. अबे आजा ना. Quickly, we have just. आजा ना. नहीं मालूम हुआ. जल्दी से. शर्ट पीछे से उतार दिया. पीछे से. Now at times, what we do, we see this muscle, what this muscle would be? Erectus spinatus, and what we do? When they have complained over here, what we do? All the ultrasound, all the modalities, they are done over here. But let's do some extension. Now, if he's doing proper extension, see these muscles, where they are coming from. Thank you very much. Now remember your patients. Remember your patients, they come to you and say, Doctor Saab, dard yahan se shuru hoti hai aur wo niche tak jati hai. That pain is particularly because they have this posture. And now what happens with this posture? If they have hyperkyphosis at the thoracic region. Let me show you that. With these muscles, these smaller muscles acting from the lamina of the vertebra to the spine of the vertebra. Now this is a normal posture and the body is controlled by all these smaller muscles from here, the sagittal positions, whatever they are controlled. Now, let's put that into the typical hunchback posture. What happens if a muscle was like this initially and its line of action was this, right? Now you have put that muscle, put your vertebra like this, and now line of action of your muscles is following your vertebra. And if they are trying to pull from this position, their line of action is more posteriorly, and they are acting now on the lumbar spine, asking them to, the muscles of the lumbar area, asking them to do more work than that which is required. It is the line of action, the posture. Why you say, honestly speaking, 90% of the time, I would tell my patients, oh, अपना posture ठीक रखो भाई. Lekin never knew before that why this posture is important. If I'm having this posture, okay, forget it. That posture, lumbar ko kya farak padta? What's the wrong with the lumbar? But now I know this thing, that if you have thoracic rising from there, these lumbar muscles arising from up there, if you have your thoracic vertebra like that, you have a direct effect on your lumbar area. We are not talking about any discal pathology, remember, in this. Disc is far too away. There are pressures on the body, there are pressures on the vertebrae, there's a different talk altogether. I can, Dr. Saleem, I can spin more snakes in the market, but I don't want to. Quadratus lumborum and psoas major, if you remember psoas major, that's all again arising from the lumbar vertebra anteriorly, and quadratus lumborum also arising posteriorly somewhere from the lumbar vertebra and going on to the sacrum. What if this is psoas major in front of you? Yes, this is anteriorly. This is psoas major, whereas posterior. Now, as they are lying side to side to each other, it was thought that these two muscles, both these muscles are foot buttress, share instability, with quadratus lumborum being more effective in all loading modes. Now, in loading modes, where what I see, loading modes on all the loading modes, which means flexion, extension, lateral rotation, they have seen electromagnetically, electromyographically, that quadratus lumborum in all these activities is very active. And quadratus lumborum has vital attachment on the transverse process, and the fibers are cross-linking vertical. Last word about the rectus abdominis. Sorry, with all the biomechanists, sports science people, sorry, I'm going to go into this detail a little bit. The problem here, when we train sit-ups, we tell people, okay, this sit-up is for the upper abdomen, and this sit-up is for the lower abdomen. For God's sake, there is only one muscle, as you go into the sagittal direction, there is only one muscle which starts somewhere from the ribs here and goes to your pubic area. It's one muscle. Why God has created all these segments over there, segments of these muscles? Just because if we were to contract in a sit-up, if we were to contract one big muscle with a long movement arm from here to here, then that would buckle up and press your viscera inside. While pulling sit-ups, that would have compressed your, and apart from your fat belly, you would have seen something coming out or popping out from here. So that's why, in order to avoid this compression of the viscera and the muscle buckling up and showing up, God has created small fascicles into it. Its nerve supply is coming from one source. So whenever you are doing that, even the upper, if you are very happy with doing that sit-ups, that's fine. There is no need to do that lower sit-ups. Flex knee, doing a little bit of upper sit. You are actually activating whole of this muscle till here, not the upper part of this muscle. So there is nothing, no concept of this having upper abdomen anteriorly. I'm not talking about on the brachial portions, I'm talking anteriorly. There is no concept of having upper abdominal treatment and lower abdomen.
What's the degree of core factor on that?
Let's even you can buy. Not first of all, I cannot say anything about six packs. I can't have that. So, theory about six packs that you train these muscles. That's how these six packs are built, because they are intersections between these muscles. So, simple.
Actually, it's not related. Actually, it's not related with the upper abdomen or the lower abdomen. They are actually the variety of the exercise, because variety has a spice. So if you're doing the upper, you do the lower, you do the oblique, you do the lateral oblique, and the way you bring up certain number of the reps from a person.
You charge more.
Yeah. This is how the things are being done.
But this is the gimmick of the market. Yeah. Please don't do this with us. This is the
nothing to do with
how we capture the market. हमने market कैसे capture कर रही है? बिल्कुल ठीक है sir. You can add variety to that, but this is for the part of the explanation only, that when you are doing. But let me tell you, this is I'm saying. I stick myself to this master and analytical configuration of this. Honestly speaking, if you go towards the pressure of doing these sit-ups on the lumbar discal area, you would be amazed to know. And your standing posture, how much your disc is taking pressure. When you are sitting, how much pressure you are taking. And when you are crouching and sitting forward. आप लोगों को क्यों कहते हैं? Why do you tell people, please stick with the back or पीछे रखो straight back? We all said it, but we never knew why we did it. There are different pressure changes in all the lumbar discal area, which amounts to about 3,000 kilonewtons or 3,000 newtons also. So it's a big pressure on these muscles or these areas. So remember that when now. Please, whenever, from now onwards, I would request you to, whenever you prescribe an exercise plan for anyone, you have a defined diagnosis, okay, erectus spinae, okay. Please don't work only on the erectus spinae at the lumbar area. Work a little bit up. And if you are taking a patient to a rotation where there is an end range of motion at the lumbar vertebra, always remember here, you are putting your intertransverse side and rotators into pressure. So when you have this manual therapy done, please do it. I love it. I love to do manual therapy and love to see manual therapies. But always remember that when you are taking lumbar spine into full rotation, keep a little bit short of the end range. Whatever you want to achieve, you will achieve. You will achieve. Whatever you want to achieve, you will achieve. Don't take it to full rotation. Yeah, extension in pars articularity. There's one very positive test for, and it has got about 90% of the specificity. That extension, going into extension and asking him to lift his leg. Even if the pain is on the left side in right-handed bowler, when he would extend and lift his leg, he would have pain in that particular area. Shuru in the beginning, when this player comes to you, he actually cannot tell you that pain is limited to this much area. But with the passage of time, as edema subsides, he would definitely tell you that I have a pain in this small area. Now, if you are a thinking clinician, you would straight away think, okay, what it would be? It has got no radiation. Acute disc, okay, rule that out. It's somewhat bilateral. Facet joint in a young man, it could be that facet joint. And the pain is there for past 6 months. And you have done all the treatments. Please be suspicious about that patient. And especially, we'll put this paper somewhere in coming years if I live that longer. That lanky, thin fast bowlers, with whatever the action type they have, they are very prone to develop this pars articular fractures.
But sir, it could be fascia also.
It could be facets, लेकिन facets ठीक हो जाते हैं यार. 6 महीने में कौन सा facet रहेगा? So you could don't have questions. Any questions, sir? Treatment? That's $1 million treatment. I'm not going to tell you that. Let the things roll. I promise you that this is a part of our lumber group of lectures. This is a part actually. That's why I rushed. That's 2 lectures are combined into one for the sake of Dr. Nadeem. There's 2 lectures. That's why I missed that on thing, because I combined 2 last night and I had a severe diarrhea. Honestly speaking, you are lucky that I have diarrhea. I didn't speak much.
You have been eating outside.
No, sir. No, sir. I've been eating this outside foam. That's the only problem. Probably whatever. So that's a part of what I told you, that lumber thing. What we are going to do a 5 days workshop. That includes that manual therapy also. And wherever you want to do, we are ready.
I'll arrange.
Wherever you want to do for this education, let's go for it. Right or wrong, we will do that.
Thank you very much, Dr. Saleem. There is little change in the program today.
No lunch?
Sir, you don't need lunch after these snakes.
Lunch right after this. And I think that we want to take our foreign guests a little earlier to Damnico and that restaurant in Monal. So we'll be leaving earlier. So 4:30 we'll be in the lobby and we'll be leaving for Monal. And there will be only 1 lecture after the lunch. So that will be Mr. Job. And all of you must come back precisely by 2:15.
2:15. Thank you very much, guys. Thank you very much, guys. I'm leaving today, and it has been lovely talking to you. It's a brilliant audience. And sir, I take home all the messages, and I work on them. Actually, I work on them because when you are asked some questions, it has got some meaning in it. Good or bad, if you feel that is good, you work on that. If it is bad, you just put that in box. So I always take messages from here. And thank you very much for all your comments.
Thank you. Very thank you.